sir.
Hmm.
Neonatal resuscitation is a series of actions used to assist the newborn babies who have difficulty with making the physiological transition from the intrauterine to extrauterine life. Regarding the neonatal resuscitation algorithm, which is given in 2020, antenatal counseling with team debriefing and equipment check is must. And after the birth of the baby, which is done within the first minute after birth, which is the initial assessment, we have to check whether the baby is a term gestation or good tone, or whether the baby is breathing or crying. If the answer is yes, then the infant stays with the mother for the routine care and warm and maintain the normal temperature and position the airway and clear the secretions if needed. Dry and ongoing evaluation is needed. And if the answer is no, warm and maintain the normal temperature and position the airway, clear the secretions if needed, dry and stimulate. And then next step is we have to check whether the apnea or gasping, if the and if heart rate is less than 100 per minute. And if the answer is yes, we have to consider positive pressure ventilation and saturation SpO2 monitor and consider ECG monitor. And if there is no apnea or gasping, if they, check whether there is labored breathing or persistent cyanosis. If the answer is yes, then position and clear airway, and we have to check the SpO2 monitor, and supplemental oxygen may be needed, and consider CPAP. And still check for the heart rate again, and if the heart rate is still below 100 per minute, check the chest movement and ventilative correction steps if needed, endotracheal tube or LMA if needed. And if the heart rate is normal and not below 100 per minute, post resuscitation care and team debriefing can be done. And if all the corrective steps are done, and if the heart rate is still less than 60 per minute, intubate if not already done, and check do the chest compressions, coordinate with positive pressure ventilation, and 100% oxygen should be administered, and ECG monitor should be checked, and consider emergency umbilical venous sampling. And if the heart rate is still less than 60 per minute, consider IV epinephrine. And if heart rate persistently less than 60 per minute, consider hypovolemia and pneumothorax. And ongoing assessment, regarding ongoing assessment, we have to check for heart rate, respiration and oxygenation within the first 30 seconds, and clearing the airway by properly positioning the infant and sniffing position, where we have to keep a shoulder roll and headrest, and glabella and chin should be in same horizontally aligned, and external auditory meatus and suprasternal notch should be horizontally aligned, and neck should be wide and open. Avoid deep suction in healthy vigorous babies, since there is the risk of vagal mediated bradycardia. And temperature control is important, and our goal is to maintain normothermia, and to maintain the axillary temperature of 36.5 degrees Celsius. We have to cover the infants with warm blankets or any polyethylene from neck down, and we have to avoid the evaporative heat loss. And servo controlled infrared heaters can be kept to maintain the temperature around 36 to 37 degrees Celsius. And in infants with hypoxic ischemic encephalopathy, controlled hypothermia, where the temperature at 34 to 35 degrees Celsius is implemented. And oxygen, regarding oxygen, positive pressure ventilation with room air is suggested. Positive pressure ventilation with 100% oxygen is needed if chest compressions and medications are needed. And regarding the ventilation, breathing begins 30 seconds after the birth and is sustained by 90 seconds after birth. And a few minutes after birth, the respiratory rate is 40 to 60 breaths per minute, and there should be no pause between inspiration and expiration, and this maintains the FRC. And if there is apnea and bradypnea, this prolongs the exhalation and decreases FRC and causes hypoxia. If hand ventilation is required, initial breath should be 1 second or less, since the recruitment maneuvers may worsen the outcomes. And inflation pressures of 20 to 25 centimeter of water and PEEP of 5 is recommended. And ventilation is performed at 40 to 60 breaths per minute. And we have to reassess the heart rate, color, and breath sounds. And rising heart rate is the best assessment of adequate ventilation. And regarding endotracheal intubation, it should be in the neutral or sniffing position during both bag and mask ventilation and endotracheal intubation, and appropriate size ET tube with the tip 1 to 2 centimeter below the vocal cords, depending on the size of the unit, should be chosen. And distance from the tip of the tube to gums, where uh, uh, 7 in 1, 2, 3 and 4 kg infants are 7, 8, 9, and 10 centimeter. And regarding the size of the tube, less than 1.5 kg, 2.5 mm internal diameter tube is used, and 1.5 to 2.5 kg, 3 mm tube is used, and more than 2.5 kg, 3.5 mm tube is used. And successful tracheal intubation can be observed by bilateral chest movement with each mechanical inspiration and observing condensation of ET tube during exhalation. And regarding cardiac compressions, the thumb encircling technique is favored over two finger technique, and both the thumbs on sternum and allow fingers to support the back, and compress the sternum to approximately 1/3 of the depth of the chest, and 3 compressions is preferred over the 4 compressions in the rate of 90 compressions and 30 breaths per minute. And heart rate is evaluated every 45 to 60 seconds, and if still the heart rate is less than 60 seconds, then medications should be considered. Mainly epinephrine is given, IV route is preferred, and intraosseous and umbilical venous catheters can be life-saving. Epinephrine is given in the dose of 0.1 to 0.3 ml per kg of 1:1000 concentration, and 0.01 to 0.03 mg per kg followed by 1 ml saline flush should be given. If no IV access is obtained, higher dose of epinephrine via the endotracheal tube is given. That is 0.5 to 1 ml per kg of 1 in 10,000 concentration. And if this is given via ET tube, and if IV obtained after this dose, second dose can be given without any delay. Routine redosing every 3 to 5 minutes should be done, while re-evaluating the heart rate every 45 to 60 seconds. Naloxone is not recommended as initial response to respiratory distress in neonatal respiration. And regarding detection of hypovolemia, we have to measure the arterial BP and do the complete physical examination by skin color, capillary refill time, and extremity temperature, and pulse volume and perfusion. Venous pressure of normal neonates is 2 to 8 centimeter of water, and if less than 2 centimeter of water, hypovolemia is suspected. And CVP is important in detecting hypovolemia. And regarding treatment, expansion of intravascular volume with blood and crystalloids is needed, and RH negative type OPRBC is given in delivery room even before the neonate is born. It is given in the rate of 10 ml per kg slowly over 10 minutes. And regarding the resuscitation equipments, the resuscitation beds are placed at the level of position of neonate's head below the level of the lungs, which promotes the drainage of lung fluid and decreases aspiration of gastric contents. And equipment for tracheal intubation is zero and shade laryngoscope blades, and pencil type laryngoscope handle, and 2.53 3.5 mm ET tube, and a suction catheter which easily fits into each size tube, and a ventilation system where the ventilation rates at least 150 breaths per minute, and we have to maintain the PEEP, and modified Jackson-Rees or S system is used, and avoid excessive pressures and tidal volume, and we have to monitor the airway pressures, and blood gas and pH measurements can be done within 10 minutes of drawing the blood sample. And umbilical arterial catheters is used for measuring the arterial BP and used for measuring ABG and pH. And it is used for mainly infusing the emergency fluids. Thank you, sir.
Okay. Did you time when you prepared this answer? How much time it take? to write all these points? That's an exhaustive answer. Will take a long time to complete your examination. Okay, so you have to somehow modify and try to prune the. I think you need not dwell too much upon the instruments that is required, and of course the size of the electrical tube based on the weight is very important. But other points, I think all of them can be trimmed a little bit so that it can present the answer within the 20 minutes that you have. Okay? And one important point all of you should understand is neonatal bradycardia. What is the main reason for that? This requires a resuscitation. Supposing a child is born with an Apgar score of, is there any need for doing Apgar scoring in the neonatal resuscitation?
It's a we can just
usually we first
identify
assess the Apgar score at 1 minute, isn't it? Before you
Yes,
think
sir.
of resuscitation. Then you do a review at 5 minutes and then review at 10 minutes. Okay. So the activity, cry, color, grimace, okay, that is the expansion for that. And heart rate and respiratory rate are very important. And newborns are invariably born bradycardic because of lack of respiratory attempts. The hypoxia only triggers the bradycardia. As it is, the cardiac function is normal in all babies, newborn babies. But it is suppressed mainly because of lack of respiratory activity when they are born. There are several reasons for that. Okay, why hypoxia produces bradycardia in newborn children as well as in infants up to the age of 1 year? Anybody else who can answer that? Why bradycardia is more common in the presence of hypoxia? What will be the response for hypoxia in an adult? When tissues are not receiving adequate oxygen, what will the heart do to restore the oxygenation? Tachycardia. But why children, especially newborn and infants less than 12 months, they always develop bradycardia in the presence of hypoxemia? Damodaran, Kamal. It's a very basic pediatric physiology question. Because their sympathetic system is not well developed. Okay, it takes up to third year of life. Only up to when they grow up to 3 years old, they become sufficiently innervated by the sympathetic system. Until then, there is a parasympathetic dominance. So any situation that causes hypoxia, hypotension, the heart will only go for bradycardia instead of tachycardia in children. Okay. So the first resuscitation aim or point you should remember is restore the respiration, the heart will pick up automatically. Okay. So that is why they give so much of importance to making the airway passage clear, then breathing is attempted, then only circulation is taken care of. ABC works out very well here. The pulse is not indicated in pediatric resuscitation. That is compression only. Life support is not important in pediatric newborn resuscitation. It is respiration which you have to ensure that oxygenation is done well, then automatically the pediatric heart will pick up. Okay, so that is the important point that we have to remember. And all other preparations are wonderfully done by you, very detailed and very exhaustive. But try to concise, make it smaller, summarize, and then try to make it that you can enter all the points in your answer paper within the 20 minutes time. Okay.
Yes.
Complete your
My
next
third
topic.
Yes, sir.